Dear audience, dear chairs, welcome to my 15-month progress report. My PhD thesis title is The Relation Between the Maternal Factors and Birth Defects. My name is Zihan, and I'm a biostatistician currently working in the Department of Obstetrics and Gynecology at Semmelweis University. My vision is to provide a closer maternity counseling to prevent birth defects, and my mission is to increase the mother's awareness and education to make fewer birth defects. Currently, I have two specific goals. The first project is about the risk assessment of the congenital birth defects based on the maternal factors in early pregnancy, which started from September 2023. It is a systematic review and meta-analysis. And the second project is investigating the association between the maternal risk factors and the congenital birth defects, which is a case control study started from October 2024. Let's start from my first project. Congenital birth defects account for 1% of prevalence in the newborn babies, which is the leading cause of the newborn deaths. According to the data from the European Registration of the Congenital Anomalies and Twins, for the mothers with severe congenital birth defects babies, only 40% of them receive the prenatal diagnosis, and only 20% of them receive it before 25 weeks of the gestation. It is worth noting that up to 30% of the congenital birth defect cases are associated with the maternal environmental factors. So, we aim to identify the maternal risk factors that are associated with the congenital birth defects. Our clinical question is, what maternal environmental factors are associated with the risk of the congenital birth defects? We use the PICO framework. Our populations are pregnant women. Exposures are maternal risk factors. Comparison is absence of the risk factors. And the outcomes are congenital birth defects. We make a hypothesis here. Some maternal factors will increase the risk of developing congenital birth defects. The systematic search was conducted on November 16, 2023, based on 3 databases. Our search key has been divided into 3 domains. The first domain is pregnant women and its synonyms. The second domain is risk factors and maternal exposures. The last domain is congenital birth defects, and it's the most common phenotypes. After 2 cycles of selection, we've got 67 eligible articles. Additionally, 19 articles were obtained from the reference tracing. Finally, we've got 86 articles in total. Currently, we finished all the analysis. Due to the time limitation, so I only would like to present 2 of them. The first figure shows the association between the maternal diabetes, pre-pregnancy diabetes, and the risk of the congenital birth defects. The maternal pre-pregnancy diabetes was diagnosed by the fasting plasma glucose and OGTT tests based on their medical records. And some of studies, they also use self-reported data to record their chronic diabetes. As you can see in this first plot, we have included 21 studies in total. And as you can see, these studies are all case control studies or cohort studies. The I-square is 87%, which indicates a high level of the heterogeneity, and the pooled odds ratio is 2.91, with the clinical relevance and statistically significant. That indicates that the offspring of the mothers with pre-pregnancy diabetes, that means the chronic diabetes, their offsprings have almost 3 times increase the risk of getting congenital birth defects compared to the mothers with a normal glucose level. A second first plot is association between the maternal smoking and the risk of the congenital birth defects. The maternal smoking data was collected by self-reported data, and in this study we include 19 studies. And also they are all cohort studies and case control studies. The I-square equals to 83%, which indicates a high level of the heterogeneity. We think this heterogeneity may come from because of the different study types, and some countries they have some bans for smoking because of religions. And the odds ratio is 1.28 with the clinical relevance and statistical significance. This result suggests that mothers smoked during the first trimester of the pregnancy will increase their risk on their babies getting congenital heart defects compared to no smoking mothers by 82%. Of course, this study has some strengths and limitations. The first strength is we include different maternal risk factors categories for the congenital heart defects, and also we include a high number of the included mothers with their infants. The last but not least, the rigorous methodology was used in this study. However, we should pay attention to various cutoff values in some risk factors. Self-reported data outcomes was assessment, as I mentioned before, such as the smoking and the diabetes, and also alcohol consumption data. The last one is no consideration of the covariance. That means some studies, they only use the univariate model. In conclusion, diabetes, obesity, smoking, and chronic hypertension were found to be the critical marginal risk factors for congenital heart defects in the spring during the first trimester of the pregnancy. This study may contribute to the pre-pregnancy counseling and the pregnancy care. Finally, we highly suggest for the future study to conduct a longitudinal study to investigate the treated and untreated disease effects on their offsprings, and also conduct a population-based study to investigate the impact of the demographic factors on the relationship between the marginal factors and congenital heart defects. Currently, we are doing our second submission. Unfortunately, we were rejected by the AJOG, so they suggest us to transfer our submission to their subjournal. And second project is a case control study, so it should be the continuous project. As far as I know, many population-based cohort studies or case control studies focus on this topic. We select some critical marginal risk factors, for example, diabetes, obesity, smoking, alcohol consumption, hypertension, and medications. However, most studies focus on only one single marginal factor, and they are lacking of a comprehensive analysis based on the patient registry data. So, we aim to conduct a nationwide population-based case control study to examine the effect of the several marginal risk factors on congenital heart defects. Our clinical question is, do some marginal risk factors increase the incidence of the congenital heart defects? Our populations are mothers with their paired singleton births, and exposure is the presence of the marginal risk factors. And our outcome is incidence of the congenital heart defects. We make a hypothesis here, some marginal risk factors will increase the incidence of the congenital heart defects. We use the data from the Hungarian case control surveillance of the congenital abnormalities, which recorded from 1980 to 2009, which include near 90,000 records. We include singleton births paired with their mothers, including terminated pregnancy, stillbirths, and live births, and also cases with congenital heart defects with their common phenotypes. And the last but not least, only cases with a single congenital heart defects will include our study. In summary, two ongoing projects. The first one is a systematic review and meta-analysis has been submitted in December 2024. And the second one is a case control study plan to submit during the July of this year. Thanks for your attention. He was an active nature and yet a founder of learning, and he was not ashamed to ask and learn of his inference. Thank you very much.
Congratulations for your presentation. I have just one question.
Yes.
Because it has a difference, for example, the patients suffer from type 1 or type 2 diabetes and between the risk factors of the congenital heart disease.
Yes, I can tell you that we include both types of the diabetes. So we conduct 3 analyses. The first one is to do the overall chronic conditions. Second analysis is based on type 1. I remember the number it suggests should be 2 times increased risk compared to the mothers with normal glucose level, and the type 2 is much hazardous. So to the congenital heart defects, it's about 3 times. So that's the way we have done this. And also for the diabetes, I have to say, we also did some analysis based on the gestational diabetes. However, the journal reviewers said we shouldn't include it because they usually happen during the mid of the pregnancy. Actually, some situations that the gestational pregnancy usually happen in the mid of the first trimester, and it can be lasted during the mid trimester. So they suggest us to delete this risk factor and to do the analysis again. So we just need to stick to the reviewers' comments. Yeah, that's what I want to say. Thank you.
I would also have a question to the first project. Mm-hmm. You mentioned as a limitation that you hasn't considered covariates, and you have a high amount of manuscripts and articles in your meta-analysis. And my question and comment would be: have you had articles with multivariate model, and why not was your plan to do subgroup analysis with multivariate model articles?
Yes, that's a very good point. Yes, it should be a very good idea to do a separate analysis. Yes, but in our study, we have done the subgroup analysis based on the risk of bias. That means we have separated to the high risk of bias, moderate, and the low risk of bias. So that should be the 3 subgroups. And according to our criteria, if this study has only included univariate model, and we should summarize that they are in the high level of the risk of bias. So we actually we have done this. So we have done this inside our paper. So I can tell you that the results and the heterogeneity didn't change a lot. I mean, it didn't change a lot. So it's a very interesting question. So especially for the results, so the odds ratio didn't change a lot. So I think we need to check further to make the further study to check the demographic factors. As I mentioned, that how the demographic factors affect on these results. Yeah, that's the point for the future study.
Thank you very much. And to the smoking topic, were there any information about the importance of the amount of smoking? What are your experiences during the systematic search about this question?
So as far as I know, so this smoking has a very significant effect on this outcome, right? So as also
do you have any information about the amount of smoking? How many cigarettes per day?
Oh yeah. We have it. Sorry, I just understand.
No problem.
So yes, some studies they have some categories for the low smoking, moderate smoking, and high strong smoking. So they have cigarette. For example, per 1 to 3 cigarettes per day, it should be the slight smoking, and 5 to 7 should be the moderate, and 7 to 9, more than 7, it should be the high heavy smoking. So that should be some criteria. However, in some studies they don't have these categories, so they put together as the smoking. If at least you smoking, you are smoking at least one cigarette, they can account for the smoking situation. So that's the point. And
Thank you.
And I also want to say we need to set a standard for this situation, for these risk factors, because there's no such critical standards for this. Yeah.
Thank you. I also would like to ask one question about this smoking thing. It's an interesting topic for the gynecologists, apparently, or obstetricians. So I would like to ask you that, did you consider to pull some articles which are actually checking the objective factors of the smoking? So I mean, like not self-reports, but, or did you find any studies which were like reporting cotinine levels, for example, or?
Actually, no, because if we check the such chemical level for the patients, I think it's very difficult. So there's no study. They just use the self-report data, and also not only for the active smoking and also for the passive smoking, they are all the self-reported data. That means I think I received the hazard from the passive smoking. So I think, okay, I'm standing at the smoking area. So that should be the limitation for these risk factors. So we can't do anymore.